In this video, we're talking about blood pressure. Blood pressure is a very important consideration in cardiovascular health. It's what keeps blood flowing through the vasculature. So your body can't let it get too low or blood won't circulate, but it's also important that blood pressure not be too high. High blood pressure, chronic high blood pressure, can damage the arteries as well as the heart. When we're talking about blood pressure, we're talking about the force exerted on a vessel wall by the contained blood. So if here's your vessel wall, and you have blood flowing through it, that blood, the blood that's in that blood vessel, kind of pushes out on the vessel wall. And that's what blood pressure is. Usually, when we talk about blood pressure, we're talking about the systemic arterial blood pressure. So the arteries of the systemic circuit, what's the pressure in those arteries? And usually the larger arteries near the heart. When we measure blood pressure, we measure it in millimeters mercury. Blood pressure is related to blood flow and to resistance in the vessels. Blood flow is the total volume of blood flowing through a vessel, an organ, or an organism in a given period. If you're talking about total flow, you're talking about the volume of blood flowing through the entire organism, the entire vascular system. So it's equal to cardiac output. Total flow is essentially constant at rest. However, if you are talking about blood flow through a particular blood vessel or through an individual organ, you can get huge variations in blood flow according to the needs of the organism or of that particular organ. For example, take the skin. When you're warm and you need to cool down, blood flow to the skin increases so you can shed heat. But when it's cold and you need to conserve that heat, blood flow to the skin goes down. When we're talking about blood flow to a tissue or to an organ, we use the term perfusion. So you talk about perfusion of an organ or perfusion of a tissue. Blood flow is given in units of milliliters per minute. So it's a rate. The amount of blood flowing through a particular tissue or an organ or through the entire organism each minute. Now, resistance is opposition to blood flow. So resistance is basically the force that blood needs to overcome in order to flow. And it pretty much has to do with friction. So if you rub your hands together, that generates a little bit of heat because of the friction from your hands rubbing together. Well, there's friction when blood passes through a blood vessel as well. Friction is primarily in the systemic circulation, so far from the heart, and that's because as you get further from the heart, as the blood flows, the vessels get smaller, and the smaller a blood vessel is, the more resistance it exerts. This friction in the systemic circulation, resistance in the systemic circulation, is referred to as peripheral resistance. So what does this have to do with blood pressure? Well, it's the heart pumping that generates blood flow. That's what gets blood flowing. Blood pressure is what happens when that flow is opposed by resistance. So if resistance dropped to 0, then blood pressure would drop to 0, and you wouldn't get much flow. So blood resistance is basically friction of blood along the vessel wall, and there are 3 things that affect this friction. Blood viscosity is the first one, so basically the thickness of blood. This is pretty constant. So your blood viscosity really doesn't change unless you have something going on with your red blood cells. If you have polycythemia, which is an increased overproduction of red blood cells, that will increase your viscosity. But if you have anemia and you have decreased production of red blood cells, it will decrease your blood viscosity. Blood vessel length is another factor that determines resistance. The longer the vessel, the more encounters you have between blood and vessel wall, so the more resistance you have. However, in adults, blood vessel length is also constant. If you're talking about children who are still growing, yes, their blood vessels get longer, just like their bones and muscles do. So you do see increase in resistance in children as they grow. But in adults, this is pretty much unchanging. So these two are constants. This third factor down here, blood vessel diameter, is highly changeable. So blood vessel diameter plays a role in resistance and controlling resistance and thereby controlling blood pressure, because if you have a smaller blood vessel diameter, you have more resistance, and a bigger blood vessel diameter gives you less resistance because there's less blood coming into contact with the vessel wall if the vessel wall is expanded, if the blood vessel is bigger. Blood vessel diameter is probably the most important of these three sources of resistance because it's so changeable. That means that this can be manipulated by your body in order to regulate blood pressure. So there's this relationship between blood flow, blood pressure, and resistance that can be summed up by this equation. Blood flow is equal to the difference in pressure divided by resistance. So what this basically means is that flow is directly proportional to pressure. So if you have greater difference in pressure, you have greater flow, but it's inversely proportional to resistance. If you have greater resistance, that actually decreases your blood flow. All right? If you can take this equation and you can flip it around to say that blood pressure equals flow times resistance. But now, since flow is basically cardiac output, when you're talking about the system as a whole, you could also say that pressure equals cardiac output times resistance. So now we can see that if cardiac output goes up, you get an increase in blood pressure. Let me just say blood pressure up there too, BP. But also if resistance goes up, you get an increase in blood pressure. Your body manipulates resistance by adjusting blood vessel diameter, and this is an important way to control blood pressure, to regulate blood pressure in the short term. So if we're talking about more immediate adjustments to maintain a stable blood pressure, we're talking about changes in blood vessel diameter. All right? If you are talking about longer term changes in blood pressure, then you have to get the kidneys involved. And what the kidneys can do is the kidneys can regulate the amount of water that is retained in the body or lost to the urine. And so by regulating water retention, the kidneys can adjust cardiac output. If you're holding on to more water, blood volume is going to go up and cardiac output is going to go up. If you are losing more water in your urine, blood volume is going to go down and cardiac output is going to go down. Okay, so changes in resistance by changing blood diameter, short-term regulation, changes in cardiac output by regulating blood volume is longer-term regulation. I mentioned that when we're talking about blood pressure, we're usually talking about blood pressure in the arteries. If you're talking about pressure in the capillaries or the veins, blood pressure is significantly lower in both of those types of blood vessels. This diagram shows you the changes in blood pressure as blood flows further away from the heart. So starting at the heart, blood moves out to the aorta, the largest artery, and then through the arteries, through the arterioles, through the capillaries, venules, veins, and eventually into the vena cava. So blood pressure is highest at the aorta because the aorta is closest to the pumping action of the heart. In the aorta, you also have massive fluctuations in blood pressure as the heart contracts and relaxes. So your systolic pressure, that's the top of this line, this top line, that's the pressure in the aorta and arteries when the heart is contracting, when the ventricles are contracted. Okay? The diastolic pressure, this lower line, is the pressure when the ventricles are relaxed. The blood isn't actually feeling that push from the heart at the moment, or not feeling as much of a push from the heart, so the pressure goes down. This fluctuation, this high systolic, low diastolic, blah, 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 blah. That's why you can feel someone's pulse when you palpate their superficial arteries. What you're actually feeling is that rhythmic push of systolic pressure with each heartbeat. All right. Now, as you continue on from the arteries into the capillaries, blood pressure dissipates because in the arteries, you have a few vessels, but those arterioles branch out into capillary beds. So that blood is distributed among several different vessels, and that blood pressure is distributed among several different capillaries as well. So it's, in essence, dissipated through the capillaries. By the time blood leaves the capillaries, blood pressure is very, very low in the veins. That's why the veins need assistance from the respiratory pump and from skeletal muscle in order to move blood through them, and also why you need venous valves to prevent backflow. So the veins essentially are feeling essentially no push from the heart. And by the time you get back to the vena cava, at the right atrium, blood pressure is essentially 0. So you saw what blood pressure looks like on the graph of systemic blood pressure on the previous slide. I just want to lay out some definitions for you here. Systolic blood pressure is blood pressure at the peak of ventricular systole. Diastolic blood pressure at ventricular diastole. Now, when you take these two pressures, you can calculate the pulse pressure. The pulse pressure is just the difference between the two, this difference between systolic blood pressure and diastolic pressure. The mean arterial pressure is diastolic plus 1/3 of the pulse pressure. Okay, so it's your diastolic blood pressure plus the pulse pressure divided by 3. So let's do a quick calculation just to see how that works. If you take a typical average normal blood pressure of, say, 120/80, right? 120 is your systolic blood pressure, 80 is your diastolic blood pressure. So to calculate the mean arterial pressure, you take your diastolic plus the difference between systolic and diastolic, so 120 minus 80, and then you divide that difference by 3. So you get 80 plus 40/3, which works out to about 93 millimeters mercury as your mean arterial pressure. Notice that your mean arterial pressure is much closer to the diastolic pressure than it is to the systolic pressure. Notice that diastolic pressure counts fully towards the mean arterial pressure, and pulse pressure, you're only taking 1/3 of the difference between diastolic and systolic. So it's not a strict average. And the reason why is because diastole actually lasts longer than systole. If you look over here, ventricular diastole takes up about 2/3 of the cardiac cycle, and ventricular systole about 1/3. So this is a weighted average, and it's weighted towards the amount of time that the arteries spend experiencing diastolic pressure versus experiencing systolic pressure. Mean arterial pressure is useful clinically because in some cases it's actually a more accurate clinical predictor, so a more accurate predictor of problems. Like if you are trying to predict a pregnant woman's risk of developing preeclampsia. Preeclampsia is dangerously high blood pressure during pregnancy. Mean arterial pressure is actually a better predictor of that than just looking at systolic and diastolic. Mean arterial pressure also indicates the average pressure that's pushing blood through the organs, the average perfusion pressure. So it can be a better indicator of how well organs are being supplied with blood. If your systolic blood pressure is lower than about 100 millimeters mercury, you may be diagnosed with hypotension. Now, there is some variation, individual variation in terms of blood pressure, so for some people a slightly lower blood pressure may be perfectly normal. But if you typically have a normal blood pressure and then your blood pressure changes and now your blood pressure is lower than usual, it may indicate that you have another problem going on, perhaps something nutritionally or some endocrine problem affecting your blood pressure. So having a slightly lower than normal blood pressure is not usually a problem, except for what it might indicate about your health otherwise. However, if you have an acute drop in blood pressure, an acute severe drop in blood pressure is a condition called shock. And this can be a problem because all of a sudden your organs aren't getting the blood that they need. There are a number of different things that can cause shock. A severe drop in blood volume is referred to as circulatory shock or hypovolemic shock, low blood volume shock. And this can happen during dehydration, during severe burns, blood loss, hemorrhage will cause, or severe bleeding will cause a drop in blood volume, which drops your cardiac output and drops your blood pressure. Damage to the heart can cause shock as well. This is referred to as cardiogenic shock. So if you have an arrhythmia or if you have a myocardial infarction or valvular disease, it can lead to cardiogenic shock. If you have blockage of blood flow to either the heart or lungs, it's referred to as obstructive shock, and this most commonly comes from a pulmonary embolism, which is a loosened blood clot that blocks capillaries in the lungs. Lastly, if you have widespread systemic peripheral vasodilation, that can lead to shock as well, because remember, as the blood vessels dilate, as they get bigger, resistance goes down, so blood pressure goes down. And widespread vasodilation can be neurogenic, which means that it's resulting from damage to the brain or the sympathetic nervous system. So there are vasomotor centers in the brain that control vasoconstriction and dilation, that control the size of your blood vessels, the diameter of your blood vessels. And if you have damage to the brain, those vasomotor centers can stop doing their job. Spinal cord injury can also keep those signals from getting to the blood vessels. Right? You can also have this widespread peripheral vasodilation in response to inflammatory stimulators. So you can have septic shock. Septic shock is where you have bacteria in your body that are releasing endotoxins that stimulate widespread inflammation. The inflammatory molecule histamine is a vasodilator, so if you have too much histamine released, you have too much vasodilation, and you go into septic shock. You can also get histamine released in response to allergies. And if you know anyone with a severe peanut allergy or severe allergy to bees, you may be familiar with the term anaphylactic shock. Anaphylactic shock is where you have a severe allergic reaction causing this widespread peripheral vasodilation. High blood pressure is called hypertension. So hypotension is low blood pressure, hypertension is high blood pressure. It's typically classified as a blood pressure greater than 140/90, right? High blood pressure is normal under certain conditions. When you have a fever, your blood pressure tends to rise. When you're exercising, your blood pressure goes up. When you're upset, when you're emotionally activated, your blood pressure goes up as well. This is all perfectly normal, but it's also temporary, okay? When you calm down, your blood pressure comes back down. When you stop exercising, your blood pressure comes back down. When your fever is gone, when you're kick that bacteria out of your system, your blood pressure comes back down. The problem becomes when you have chronic hypertension, when your blood pressure doesn't come back down. Chronic hypertension is bad for the arteries and it's bad for the heart. Think about afterload. Hypertension increases the afterload. Remember, afterload is the pressure in the aorta that the left ventricle has to overcome in order to eject blood out to the body. High blood pressure increases the afterload, and the ventricles have to work harder. What happens as the ventricles work harder is that the myocardium gets bigger, so you see an enlargement. It's trying to respond to the load, just like if you lift weights, your muscles will get bigger. If you are constantly pushing against this high blood pressure, your heart will get bigger. However, over time, that enlargement gets too big, and the blood flow to the myocardium, the coronary circulation, it can't keep up with that increased tissue mass. And so your myocardium may be getting bigger, but it's actually starved for blood. So it may be bigger, but it's getting weaker. Chronic hypertension also damages the arteries. Remember, blood pressure is the force of blood pushing on the wall of the artery, and if you're pushing too hard, it can lead to inflammation and thickening of the arterial wall. And if the arterial wall becomes thickened, it can't flex, it can't expand and contract the way it needs to with the pulsing of the heart. Chronic hypertension, there are a number of factors that play into it. Genetics is one. High blood pressure tends to run in the family. High salt or high fat intake can lead to chronic hypertension, although it's thought that not everyone responds to salt in the same way. Some people have blood pressure that is very sensitive to salt, and some people it doesn't really make that much of a difference. Stress. Chronic stress can lead to high blood pressure. Obesity can increase blood pressure. Smoking. There are endocrine disorders that affect blood pressure as well. If you produce high levels of aldosterone, you are going to be holding on to more water and you're going to have higher blood pressure. Okay. I want to take a couple of minutes and step away from talking about systemic arterial blood pressure to talk about some special concerns with blood pressure in the capillaries for a moment. Blood pressure drops significantly in the capillaries as the blood from an arteriole gets diffused into the networked capillary bed. So pressure in the arteriole is around 50 millimeters mercury, but in the capillaries it drops to 15 to 35 millimeters mercury. Blood pressure in the capillaries needs to be delicately balanced. It has to be high enough to force fluid out of the bloodstream into the tissues. But remember, capillaries have a very thin wall, just the tunica intima. So if blood pressure gets too high, it's going to rupture those capillaries. You need to have blood pressure low enough so that the capillaries don't burst. So delicate balance. That forcing fluid out of the capillaries is an important component of bringing nutrients to the tissues. There's a constant exchange of blood plasma and tissue interstitial fluid called the bulk fluid flow. And it depends on two things, hydrostatic pressure and the osmotic pressure in the capillaries. Hydrostatic pressure is the pressure of blood against the walls of the capillary. Basically, it's the capillary blood pressure. And hydrostatic pressure pushes fluid out of the capillary. So the hydrostatic pressure in the capillary is a force that pushes plasma out into the tissues. Osmotic pressure, when you think osmotic, think osmosis. Osmotic pressure is sometimes referred to as colloid osmotic pressure, or sometimes you may hear the term oncotic pressure. And that's the osmotic pressure exerted by proteins, primarily by proteins in the blood. So the proteins are solutes that cannot diffuse out of the capillary. They're too big to leave the capillary. So they sit in the capillary, they stay in the capillary, but because they're solutes, they end up exerting a force that tends to pull water into the capillary. So you can think of the proteins in the capillary as kind of sucking water back in. So hydrostatic pressure forces plasma out. Oncotic pressure sucks fluid back in. These are two counterbalancing forces. They act in opposite directions. Now, in the interstitial fluid has essentially zero hydrostatic pressure. It's in huge space under normal conditions. The interstitial fluid also tends to have very few proteins, so it has a little bit of an osmotic pressure, but just a little bit, very low. The hydrostatic pressure in the capillary and interstitial fluid and the osmotic pressure in the capillary and interstitial fluid, when you kind of take all of these and put them together, you get the net filtration pressure. And the net filtration pressure basically is a way to calculate the balance of the pressures and determine whether fluid is going to be pushed out or pulled back in to the capillary. When you're calculating net filtration pressure, you basically want to look at the difference in hydrostatic pressure minus the difference in osmotic pressure. Now let's look at the diagram to actually work that out. Now, so we're looking at a very simplified capillary bed, a single capillary. Blood flows from the arteriole to the veniole, so the direction of blood flow is like that. At the arteriole end, capillary hydrostatic pressure is as high as it's going to be. Okay, so at the arteriole end, capillary hydrostatic pressure is at 35 millimeters mercury, and it's essentially zero in the interstitial fluid and the healthy interstitial fluid, so the net hydrostatic pressure is 35 millimeters. Now the osmotic pressure in the capillary is about 26 millimeters mercury, and in the interstitial fluid it is 1. So the net osmotic pressure is 25 millimeters mercury. Now you take 35 minus 25, and your net filtration pressure is 10. Okay, and notice that it's positive. That means that the hydrostatic pressure, the net hydrostatic pressure, is greater than the net osmotic pressure, so you are going to, that positive net filtration pressure is going to push plasma out at the arterial end of the capillary. But as fluid leaves the capillary, the hydrostatic pressure goes down. If there's less fluid to push against the walls of the capillary, pressure goes down. So when you're looking over here at the venial end of the capillary bed, net hydrostatic pressure, or your hydrostatic pressure in the capillary, is down to 17 millimeters mercury. So that gives you a net hydrostatic pressure of 17. Net osmotic pressure is still the same, That doesn't change. So you have 26 in the capillary, 1 millimeter mercury in the interstitial fluid, and a net osmotic pressure of 25. But now, if you subtract these, 17 minus 25 gives you negative 8 millimeters mercury. The osmotic pressure is greater than the hydrostatic pressure, so at the venule end of the capillary, some of that fluid is going to be drawn back in. So there's a balance. You have plasma being pushed out and some of the interstitial fluid being taken back in. Anything that interferes with this balance of flow can lead to edema. Edema is an accumulation of fluid in the tissues. What you're looking at here is a condition called pitting edema, which is basically where the edema is is so severe that when you depress the skin, it stays pitted even after you remove your finger. Edema can happen when you have inflammation or vessel damage. If you've ever had a bruise that was a little bit swollen, you are familiar with edema. It's also seen with hypertension. Elevated arterial pressure means that you have elevated hydrostatic pressure in the capillaries and you get more blood forced out. So an increase in hydrostatic pressure can lead to edema. You also see edema when you have impaired synthesis of blood proteins. Remember, it's the proteins in plasma that are largely responsible for the oncotic pressure, particularly albumin, the most abundant protein in the blood. So if you can't make these plasma proteins, fluid is not going to be sucked into the capillaries. You're not going to have as much osmotic pressure in the capillary, and you're not going to get fluid taken back up out of the tissue. Right? In this situation, you can get edema, but you also get fluid accumulating in the abdominal cavity called ascites. And that's why if you have ever seen pictures of starving children with swollen bellies, part of the reason why their bellies are swollen is because they have fluid accumulating in their abdominal cavity because they aren't eating enough protein. They aren't taking in enough protein to be able to make albumin and other plasma proteins. You also see this swollen belly fluid accumulation due in patients with failing livers, because the liver is the organ that makes albumin and most of the other plasma proteins. So if your liver isn't functioning well, like if you have alcoholic cirrhosis or some other damage to the liver, if your liver can't make plasma proteins, your capillary osmotic pressure is going to decrease and you'll get more fluid staying in the tissues and accumulating in the abdominal cavity. Okay, so after studying this video, you should be able to talk about the relationships between blood flow, blood pressure, and resistance. You should be able to talk about where resistance comes from, a little bit about how it's regulated, though there's another video that will go into much more detail on that. You should be able to talk about blood pressure through the circulation, differences between arteries and veins and capillaries. You should be able to recognize these terms and either describe how to measure or calculate them. You should know the difference between hypotension and hypertension and the health problems associated with chronic hypertension, a little bit about shock. And you should be able to talk about how hydrostatic pressure and osmotic pressure contribute to exchange of fluid at the capillaries.